we've kind of covered what body image is about, briefly at least. Now we're going to move into a conversation about what happens when our body image leads to some problems. I'm going to refer to this as eating disorders, but I want to be clear that I want to make this a broader term, and I'm going to call it disordered eating. What I mean by that is I will absolutely talk about what are the diagnosable eating disorders, but there are a whole host of behaviors that don't fall neatly in those categories that are also problematic. And so there's kind of a line between when does it become an actual diagnosable eating disorder, but long before then, there may also be complications and problems. Eating disorders exist on a continuum. If we kind of break down that continuum, going from perfectly fine body image, you feel great in your own skin, you don't have any problematic behaviors, up to the other end of the continuum, which is eating disorders. There's a whole range in between there. With the not an issue, you're not going to be concerned about what other people think about you. You're not going to engage in any kinds of behaviors around food or weight. You trust your body to tell you when you're full, what you want to eat. Body image isn't an issue. That might move a little bit up the continuum to being concerned, but it's still a healthy concern. So you nourish your body to have strength and energy. You might weigh more than you would like, but you're not hung up about it. You balance your pleasure from eating with your concern about having a healthy body. You base your body image both on social norms, but also just on your own beliefs and concepts. You pay attention to your body and your appearance, take care of how you look. You might put on makeup before you go out of the house, but it doesn't occupy great hours of the day. And you try to follow some dietary guidelines. Then you might move into food preoccupation. This is where things might start to become a tiny bit of a problem. You start getting afraid of putting on weight or becoming fat. You think about food a lot. You start to begin thinking you want to change how you look or how your appearance is, what you want to eat versus what you might actually be hungry for. You might find it hard to enjoy food with other people. And you might spend quite a bit of time comparing your own body to other people. Then we move again up the continuum into disruptive eating patterns. This might actually move into some of the behaviors that can be problematic. So that might be things like diet pills, laxatives, making oneself throw up, spending excessive amounts of time on exercise. You might fast for long periods. You begin to feel a sense of accomplishment from not eating, and your body shape might keep you from doing activities like dating, or you may put yourself in dating positions in relationships where you're not being treated very well, but you feel not so great about yourself, and so you stay in an unhealthy relationship rather than standing up for yourself. And then moving to the far end of the continuum, the eating disorders, so becoming afraid to eat in front of others, terrified of becoming fat, so not just uncomfortable with the idea, but legitimately terrified of becoming fat. There may be behaviors of regularly stuffing oneself with food and then getting rid of those calories through exercise, or then followed by long periods of fasting. You may actually come to the point of hating your body or isolating from others because of how you feel you look. So if we move from the continuum of an actual eating disorder, that continuum goes from restriction up to binging or overconsumption. And a person can move along that continuum. They don't necessarily stay in one point on that line. It's not uncommon for somebody to start off with maybe a very restricting type of eating disorder and then move into a binging or overconsumption type of eating disorder. The two most common that most people have heard about are anorexia nervosa and bulimia nervosa. The key points in anorexia nervosa is either severely underweight or really significant drop in weight in a short amount of time, a relentless quest for thinness, an absolute dire fear of becoming fat, but also a distorted perception of oneself. Some of the clients that I have worked with look in a mirror and legitimately see themselves as grossly overweight, despite the fact that they are actually, in reality, quite emaciated. They do not see themselves clearly. And then that intense fear of becoming fat or gaining weight then leads to the behaviors that perpetuate the eating disorders. There are two subtypes actually of anorexia. So most people aren't aware that sometimes with anorexia, there is also binge eating. Binge eating is defined as eating a large amount of food in a short span of time, or like an amount of food that would be abnormal for the average person. For instance, it's kind of acceptable or normal for us to overeat, say at Christmas dinner. Binge eating is a larger amount of food in a shorter span of time than what would be considered normal. The person might be of normal weight, overweight, or underweight. People tend to think if there's binge eating present, that that's automatically bulimia. Another myth, people tend to think that only someone who is completely emaciated is suffering from an eating disorder. Some people think that someone with anorexia never eats. That's not true. They are just very, very restrictive. So if you go long periods of time without eating, your body at some point will demand food and energy for survival. We have this incredible survival instinct. If you think about it in terms of other things that our body requires for survival, like breathing, for instance, when we hold our breath for as long as we can and then resume breathing, how do we resume breathing? Do we just calmly begin inhaling and exhaling again? No, we go to fill up our lungs because now our body is missing that oxygen. So same thing with eating. When we go long periods of not fueling ourselves and then we eat a little bit, our body goes, no, we need lots more of that. And so oftentimes that will then lead into a binge. Bulimia nervosa is often hidden more than anorexia because the body shape may not necessarily be as indicative. There is still the worry about weight and the fear of being fat, but there's also a feeling of loss of control. Whereas anorexia, the person is usually underweight, often significantly underweight. You cannot look at a person's body and necessarily tell whether or not they have an eating disorder. Again, with bulimia nervosa, there are two subtypes. There is the purging type and the non-purging type. Most people with bulimia nervosa feel that if there is vomiting, that's bulimia. Sometimes people with bulimia do not utilize vomiting as a way to compensate for the binge eating. They might, but purging is any kind of behavior that, just like it sounds, it purges the food and calories from the body, externalizes. So that might be through vomiting, that might be through laxatives. Non-purging would be a binge followed by a long period of fasting, over exercising. So it's still a way to compensate for the binge, but it's not the purging of the food. Another type of diagnosable eating disorder, and it's called binge eating disorder. Binge eating disorder essentially is like bulimia without the compensation, without the behaviors to compensate. Again, it's eating a large amount of food in a short amount of time, feeling distress about the binge eating episodes, feeling a lack of control. But then that is not followed by fasting, over exercising, purging. And then any other type of eating disorder that doesn't fit neatly into the criteria that is set out with the other three eating disorders that I've talked about can kind of go into a category called other specified feeding and eating disorders, or OSFED. It's a category that kind of catches all of those outliers. It might be that the person has, again, in previous editions of the diagnostics manual, before binge eating disorder was an actual diagnosable illness, it would have fallen into that category. So if there are other eating disorders that require more research, that might fall into that category. There is an eating disorder called night eating syndrome that still is not yet recognized as a separate diagnosable illness, but it would fall into that category. So there's a few different disordered eating issues. So when we're talking about prevalence just means how often does this happen? How much of the population is affected? So I'll talk about percentages, and that will kind of give you a little bit of an idea of how much of the population are we talking about here. When you look at the Canadian population, about 1 million people will be diagnosed with an eating disorder. 1.5% of Canadian women between the ages of 15 and 24 had an eating disorder, and that the prevalence of anorexia and bulimia is estimated to be 0.3% and 1% respectively among adolescent and young women. And the prevalence rate of anorexia and bulimia appear to increase during the transition from adolescence into early adulthood. So that is a really key point to kind of keep our eyes and ears open. We're looking at a prevalence rate of about 3.5% in women and 2% in men. The average lifetime duration of bulimia is found to be approximately 8.3 years. So I need that to sort of sink in and percolate a little bit, because oftentimes people think if someone goes into treatment, then as soon as they come out of treatment, they should be doing better. And it's a long journey to come out the other side of an eating disorder. It takes years of active treatment. I want to point out, if you haven't already picked up on the fact that I'm quoting you a survey from 2002. I get that that is really out of date. Part of the concern about sharing prevalence rates is our Canadian statistics are really lacking. I could give you research from other countries, and for the most part, I would say that they probably line up with Canadian statistics, but we don't know. There's not a lot of money being put into the research of eating disorders in Canada. And when I have ever done professional presentations and I go through the prevalence rates, I ask the audience, if you know of someone who either is currently or has struggled with an eating disorder, can you put up your hand? Almost every person in the room puts up their hand. Now, the scientists in the room would probably say, well, some of those people are in common, right? And so that's not a scientific way of looking at prevalence. But I've also found that as I began to build this as a specialty in my practice, and people, inevitably as you get to know people and they ask, what do you do? And I would talk about, this is what I do. Almost always they had a story for me. So I find it really hard to believe that these very low numbers are accurate. I have nothing to back that up with other than anecdotal, but I just think that this is a bigger problem than what the numbers are showing us. I also think we have to recognize that key features of an eating disorder is the secrecy around it. How many people are struggling with an eating disorder and aren't ever diagnosed? How many people never pick up on the signs? I've also seen where there is a misdiagnosis, or at the very least an underdiagnosis, where the person might be diagnosed with depression or anxiety instead of an eating disorder. They clearly have an eating disorder. But if we aren't asking the right questions, if medical professionals, helping professionals are not asking direct questions, it gets missed. And also, helping professionals oftentimes do not ask males about their eating habits or their body image. Oftentimes their symptoms are missed because, let's face it, something like spending 2, 3, 4 hours in a gym is glorified. And so if guys are spending all their free time in a gym, we applaud that. We don't look a little further at, what else is going on here? I think that it is really super important to just recognize that even though if you go and do any research on your own, you're going to find that the numbers are really low that are reported. I believe that they're much higher. And as I mentioned before, that it has the highest mortality rate of any psychiatric illness. So if you look over a 10-year period of someone who is battling an eating disorder, the mortality rate is 10%. As time goes by, over 20 years, that becomes 20%. And the way that people will often succumb to this illness is their hearts give out, or there may be an opportunistic infection that sets in because their immunity is compromised. And sadly, a good number of people with eating disorders, again, depending on the research that you look at, will die by suicide. It is a horrible, unrelenting illness. It pervades every aspect of a person's life. I did come across some research from the States from 2019 that I thought actually aligns more closely to what I've just been talking about. And this research from the States says that nearly 1 in 7 males, so that would be 14.3%, and 1 in 5 females, so 19.7%, are experiencing an eating disorder by the age of 40. That's terrifying to me. Increasing treatment coverage for all eating disorder cases could avert 70.5 deaths per 100,000 individuals. There is a significant gap in the treatment end of things. So I've talked about how sometimes there is a misdiagnosis, that it's seen as depression or anxiety. Oftentimes there's a comorbidity. What comorbidity just means more than one thing happening at the same time. 70% of people with eating disorders also are dealing with depression. You've got 63.5% dealing with an anxiety disorder, 41% with OCD. There's a greater mental health conversation that needs to be happening here. I think that this is a broader issue than what the numbers are suggesting to us. In my practice, there are a couple of things that I have noticed that make me want to ask more questions. I have no science to back this up, just want to say that. This is just commonalities that I started to see in my practice. When I have had clients who come in and they talk about adopting a vegan or vegetarian lifestyle, I ask more questions. If they tell me that they have irritable bowel syndrome, if they are lactose intolerant, if they are gluten-free, these are things that kind of trigger me to ask a few more questions. For instance, if someone says that they've become vegan, I will ask them, so when did you choose to do that? Maybe their family has always been vegan. Maybe they saw a documentary about the way that animals are slaughtered, or maybe they have the ethical concerns. That is a very different conversation than, I don't want to eat meat because it's fattening. Irritable bowel syndrome, I will ask, when were you diagnosed? Have you been diagnosed? Because sometimes people will throw that out and they've never had the diagnosis. But they'll say to me, I can't have dairy because I've got irritable bowel syndrome. Again, as we explore a little bit more, it becomes a conversation about how fattening dairy is. And then the same with the lactose intolerance. Or other food groups, gluten-free. Are you celiac? Has that been diagnosed? Or is this about wanting to avoid carbs? If someone has diabetes, they're at significantly higher risk of developing an eating disorder. All of the focus on food and having to monitor their blood levels and their insulin levels, it puts a lot of unnatural focus on those things, especially if the diabetes started in childhood. And so what kind of relationship does that build for the person around their bodies and around food? Do they use the insulin as a way of managing their weight? Do people talk about religious or spiritual or cultural fasting? That may be completely harmless, but I would ask questions around that. Help me understand how that benefits your spirituality. What do you gain from that? And talk to them in a way that you're curious about their cultural practices, but also listening for, is this actually about the religion or the culture, or is this about a way to acceptably not eat? Some of the behaviors that might kind of put up a red flag, if you see people who are constantly or repetitively dieting or cutting out certain food groups, using meal replacements, that might be a problem. If there's evidence of binge eating, lots of like wrappers laying around, if there's evidence of vomiting or laxative abuse, if there's compulsive exercise, so I'm not just talking about daily exercising, I'm talking about compulsive means like a drive to do it. If you don't do it, there's a distinct discomfort around that. Having good food and bad food mentality or forbidden foods, those are red flags. If there are obsessional rituals around food, do they have to cut the food into a certain number of pieces? Do they have to chew the food a certain number of times? Can they only eat certain foods on certain days? Do they avoid meals? Are they often checking weight and body related things like their weight? They might measure themselves, they might do pinch tests or fat fold tests, excessively looking in the mirror. Have they become socially isolated? Eating disorders take up a lot of time and energy. Oftentimes, as the eating disorder moves in and takes up more and more of the person's time, something's got to go. And often what goes is the social connections. And if you think about it, a lot of what we do socially revolves around food, whether that's getting together when we're able to go back out to restaurants. Much of what we do socially has food involved. If you're trying to avoid food, you probably are going to start avoiding those social situations. Eating food really slowly, denying that they're hungry. These are all behavioral signs you might want to look out for. Physical signs. If you notice that somebody has lost a lot of weight, especially if they've lost it rapidly, don't do the whole, geez, you look great thing, because you've now reinforced perhaps a really dangerous behavior. Frequent changes in weight. So if the person's weight is going up and down and up and down, if they become really sensitive to cold, when a person loses a lot of weight, their body goes into survival mode and kind of goes, okay, something's going on out there in the environment. We have to take care of our most precious resources, which is our internal organs. So we're going to pull all the blood from our extremities into those organs. Cold hands and feet is a common symptom of somebody who's been engaging in disordered eating behaviors. If a woman loses their menstrual period, that is abnormal. A lot of times when people are athletes, they will say, well, that's part of the athletic triad and it's just to be expected. Their body fat has gotten to a particular point that it's nothing to worry about. I disagree. I think if a woman's body has shut down her period, it means the body is in survival mode, and that is not healthy. And it's often really hard to get the menstrual cycle going again normally. If there is signs of frequent vomiting, the person might end up being quite swollen around the glands that are down here because they become inflamed. The enamel on the teeth might start to erode because of the acid in the vomit. If the person becomes faint or dizzy a lot, that can sometimes be a sign. Don't take just one of these and go, oh my goodness. It needs to be a few of these things before you really start to send up the alerts. Psychologically, if the person is becoming increasingly preoccupied with their body weight, shape, and appearance, that might be something to be concerned about. Extreme body dissatisfaction or negative body image or a distorted body image. Heightened sensitivity to comments or criticism about their body shape or weight, or even just if you're kind of making comments about, I've noticed you're not eating breakfast the last couple of months. And if there's a real sensitivity around that, might mean you want to look a little closer. If meal times become a place of high anxiety, if there also seems to be a depression or anxiety, regardless of if any other signs are not present, you need to reach out for help on that one. Low self-esteem. This can actually be one of the contributing factors to an eating disorder because we live in a dieting culture and there are a lot of kids going on diets. Some kids will go on diets and it doesn't stick and they kind of go, nah, that sucked, and they move on to something else and it's no big deal. If a kid is already not feeling so good about themselves and they diet and that gives them some sense of accomplishment, they start getting positive reinforcement from others, that can then lead them down the road into other disordered eating behaviors. If there's rigid black and white, good or bad, all or nothing kind of thinking, that can also lead to some problems. If the person feels like their life is out of control or they begin to feel out of control around food. So when we're looking at treatment, let's say we've gone through some of the lists of the warning signs and you're going, oh my goodness, this is concerning to me. I have somebody that I'm really worried about. What do you do? Initially, our first priority is medical stabilization. We want to make sure that everything is going okay physically. I'm not going to say that therapy isn't important, but it's very hard to do in-depth therapy with somebody whose brain isn't working properly because it's not getting enough nutrition. So we want to make sure that we take care of the physical aspect of things first. So getting to the family doctor, getting a complete physical workup with blood work, with pulse and blood pressure. Ideally, it'd be great to have the blood pressure taken laying down and then sitting up, because sometimes if there is a significant difference, that will alert the doctors to some cardiac issues. It does not always mean that the person needs hospitalization, but it might. So we need to really look at that and make sure that if that's the treatment requirement, that that's taken care of. After we kind of look after the physical part of things, then we either want to look at weight restoration or normalized eating patterns and activity. That's when we need to have a treatment team involved with a therapist, a doctor, ideally having a nutritionist involved as well, our dietitian. Once things kind of start to move along, then we're going to move into stabilization and maintenance. This is a really long treatment process. In Calgary, there are 3 different sites that do eating disorder treatment. The Richmond Road Diagnostic and Treatment Center has outpatient services. The Alberta Children's Hospital as well as Foothills Hospital both have outpatient and inpatient treatment services, and Foothills has 6 dedicated inpatient beds. A physician referral is required for any one of those treatment options. There's also a treatment program in Edmonton at the U of A hospital, also limited beds and also physician referral required. As you can well imagine, the waiting lists can vary. If somebody from our community needed to have outpatient services, there are billet families available for young people, but there's a cost. If an adult is, let's say, going to do outpatient treatment and doesn't have somebody to stay with in Calgary or Edmonton, there are costs involved with that are not covered through our Alberta Healthcare. More locally, going to the family physician, we have private therapists in the community that people can access. Also, Alberta Addictions and Mental Health is a free service, so people can kind of establish for themselves which of those 2 options works better for them. Also, connecting with private dietitians or the outpatient dietitians through our local hospital. You might want to ask questions around their experience in working with eating disorders. One of the things that COVID has kind of taught us is we now kind of have access to a lot of different services remotely, whereas we used to feel a bit confined to the resources that we had available to us just in our community. We can access practitioners from bigger centers through virtual sessions and such. If you want to learn more on the topic, I advise trying to connect with Canadian resources. The things that you will find on American or Australian or sites from the UK are useful, but I always like to try and get as close to home as possible. The National Eating Disorder Information Center is kind of our national place to go to for information. The Silver Linings Foundation is out of Calgary, as is the Eating Disorder Support Network of Alberta. They have online support groups for people who are dealing with eating disorders, but they also have support groups for caregivers, parents, spouses, loved ones, which is also really an important part of the treatment process. And it's very difficult to provide support to somebody in the best way possible. And then, as I also mentioned earlier, Alberta Health Services. You may be sitting there ticking off a lot of boxes, either for yourself or somebody else in your life. And the question might be coming into your mind about, now what? What do I do with this? Let me first address, if you looked at this presentation and you saw a lot of yourself, I would encourage you to reach out for some help, which I know is super scary. Often there's so much shame attached to eating disorders. What I can say to you is, this is not something you chose. It's not something that you brought on yourself. It is an illness that needs to be treated and deserves to be treated. Think about how much time it's taking up in your life and how much other really good, powerful stuff you could be having in your life instead of. When I say reach out for help, to be a little more specific, start with your doctor. If your doctor kind of poo-poos it or doesn't take it seriously, try another doctor. Reach out to one of the helping professionals in our community, whether that is one of the local therapists, whether it's addictions and mental health. But do that for yourself and also for the other people in your life, because it will only continue to take up more and more of your time, which leaves less and less time for other people and other valuable things. For the second group of people who are now going, oh my goodness, I'm worried about so-and-so. If you are a parent who is worried about your child, good news, it's a little bit easier for you than it's going to be for somebody who's worried about an adult. And here's why. As a parent, you can play the parent card. You can say, listen, I've been noticing these behaviors. I've been noticing the things that you're saying about yourself. I've been noticing your clothes are hanging on you differently, whatever it might be. As much as possible, try to make it an observation rather than you are doing blah, 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 because that puts the person on the defensive. So I've been noticing, fill in the blanks, and I'm concerned. As a parent, it's my job to make sure that you're doing okay and that you're safe and that you're healthy. I feel as though we need to go get this checked out. Now, you might get resistance and you might not. If you get resistance, again, you can kind of play the parent card to say, listen, I respect that you're an individual and you can make a lot of your own decisions. This one I'm gonna make for us. If it's about going to the doctor, I think you can just say, listen, we just need to go to the doctor and make sure that physically you're doing okay. If it's a therapist, oftentimes I will say to parents whose child is reluctant to come in, tell them that you get to make the decision for the first appointment. After the first appointment, they can have a say in whether or not they come back for another appointment. That's really scary for parents because they think, oh, there's no way they're going to come back again. So that might be true, to be honest. The child may say, yeah, I'm not doing this. But what you've done is you've set the stage for the time that they may get to a place where they go, actually, you know, that person was okay, and I really do want to talk to somebody. The other thing to keep in mind is picking a therapist is a really important process. And so you want to make sure that there's a fit. If you or your child feel like that's not the right fit, then work as a team. Say, I hear what you're saying. Maybe let's try somebody else. Honestly, 9 times out of 10, 9.5 times out of 10, when parents have needed to say that to get a kid into my office and the youth is given the power or the control to make the choice about whether or not they come back, almost always they come back. So choose well in your therapist so that you can get that connection built, but just play the parent card is all I have to say about that one. If it's an adult that you're concerned about, that becomes a little trickier. But I think you can still come at it from a similar perspective. I've noticed this. I'm concerned. Can I help? How can I support you? What can I do to be helpful? If the conversation moves into maybe they're thinking about, or maybe they're a bit apprehensive about going to see a doctor or going to see a therapist, offer to go with them. Offer to take them to the appointment. Offer to help them track somebody down to go to see about all of this. And at the very least, if they're not at that point, then say to them, I just want you to know I'm here for you no matter what. And if you want to talk to me about this, I will listen. Set the stage. I asked the question earlier about do you own a scale, and more importantly, do you use the scale? You might want to just put this little sticker on your scale that the scale will only tell you the numerical value of your gravitational pull. It will not tell you how beautiful you are, how much your friends and family love you, or how amazing you are. So I thank you very much for your time in attending today's presentation and for your interest in the topic. Thanks so much.